All right, well, it's 8 o'clock. Welcome everybody to the Department of Medicine Grand Rounds. And today is very special as we kick off a series of Grand Rounds presented by this year's Chief Residents. And so I am delighted that today we're going to be highlighting the work of Dr. Nimrod Deiss-Yehiely. Hope pretty close.
Nice job.
And to introduce Nimrod, we have Dr. Coyle, our residency program director. So Andy.
Thanks, Lynn. Today I have the distinct pleasure of introducing Dr. Deiss-Yehiely as our Grand Round speaker. Dr. Deiss-Yehiely completed his undergraduate degree in biology at Brandeis University, followed by his MD training at the University of Illinois College of Medicine at Rockford. He completed internal medicine residency training here at UW before continuing on this year as a chief resident, where he's overseeing the residency's didactic curriculum. Nimrod's an active member of the Department of Medicine's Education Committee and has won numerous awards for professionalism, teaching, and mentorship within the residency program. He's been an exceptional chief resident, a gifted teacher and educator, and a tireless advocate for the residency and for the well-being and education of our residents. I know I speak for many of you when I express my gratitude for the leadership he's shown this year as a chief resident. We are very fortunate that Dr. Deiss-Yehiely will be continuing on at UW in the next academic year as a gastroenterology fellow. He's been an active researcher during his residency and chief residency, and under the mentorship of Dr. Jen Weiss, his research work is centered around colon cancer screening. He'll be speaking today about sessile serrated lesions of the colon. Please join me in welcoming Dr. Deiss-Yehiely.
Thanks for that, Andy. Really appreciate it. Just for Clint's sake, everybody sign in with code HOWGEV to that number there before 8:15 to get credit for this. Okay, so like Andy said, my name is Nimrod Deiss-Yehiely. I'm one of the PGY4 chief residents. I'm the curriculum chief. I think I've interfaced with a lot of the people who are on the call here, either clinically or in terms of research or as a part of the curriculum. Thank everybody for coming out this morning, especially my parents, my wife, my co-chiefs, all the people who have shown support for me throughout this process. Title of my talk is Sessile Serrated Lesions of the Colon, Evil Twin. So let's get started. I want to start with a little icebreaker. So in the chat, who recognizes this character? I'm just kidding. I bet like almost everybody knows who this is. This is Spock from the Star Trek series played by Leonard Nimoy. There's one very kind of famous episode in season 2 where actually the crew gets transported to the mirror universe. And in this parallel universe, they meet alternate realities of the crew members, including Spock, and nothing really displays kind of evil and cunning in this mirror universe than Spock with a goatee. So just like Spock has this evil twin in the mirror universe, I want to share a metaphor that was described in the literature by Dr. Obuck from the University of Colorado in 2015. When he was trying to describe serrated lesions of the colon, he likens these lesions to the evil twin brother of the tubular adenoma. He points out that these lesions have multiple aliases. They go by many different names. They hang out in a bad neighborhood in the proximal colon. They hide behind a mask of mucin. They're very difficult for witnesses to detect, and those witnesses are the pathologists. They're very difficult for the police to find, who are the endoscopists. They're very challenging to remove from society. There's a high rate of incomplete resection on colonoscopy. And they can be really impulsive, meaning they can progress rapidly from normal mucosa to Adenoma-carcinoma. And then the enforcers don't really know how to take care of them. And that's the GI societies have kind of inconsistent recommendations in terms of follow-up. Don't worry if you didn't catch all that. We'll come back to this metaphor throughout the talk. Okay, with that framework in mind, let's jump into a quick clinical case from 2016. So a 50-year-old female presents to your clinic for routine follow-up, just past her 50th birthday, and it's really time to start talking about the colorectal cancer screening discussion. She's hesitant to undergo a full colonoscopy due to her busy work schedule, and she's instead requested for a Cologuard test. You send her home with a test, and the test turns positive. On follow-up colonoscopy, this was discovered in her transverse colon, a 13 millimeter sessile looking lesion that was then resected. Pathology confirmed this to be a sessile serrated adenoma. And like the good primary care physician you are, you call her on the phone to update her with the results, and she has lots of questions. What does this mean? Is this different than normal colon polyps? Are these things rare? And what is my risk of developing colon cancer? These are kind of tough, yet really meaningful questions, and I hope to prepare you to answer some of these at the end of the presentation. So the learning objectives for today are to be able to name the types of serrated lesions and distinguish key features of serrated lesions, identify high-risk characteristics for synchronous and metachronous cancer, describe the challenges with detection of sessile serrated lesions, also abbreviated as SSL on endoscopy, describe the limitations of screening tests and detection of SSL, and then list the differences in test performance between the multi-target stool DNA test, known as Cologuard, and CT colonography, commonly known as virtual colonoscopy, for detection of high-risk SSL. To do that, I'll start with an introduction of the serrated lesions, talk about the endoscopic detection, talk about screening tests, my own research project, and then wrap up with conclusions and future directions. All right, let's start by kind of introducing these lesions and a little bit of a historic aside just to set the framework. So one of the most fundamental concepts of colorectal cancer is the adenoma to carcinoma sequence, a term that describes the stepwise progression from normal colon to carcinoma. This pathway is driven by the accumulation of multiple genetic mutations. Ones that we commonly learn about include APC, KRAS, and P53. It was long believed that all colorectal carcinomas developed along this pathway. However, this all changed with the work of this woman, Dr. Emina Torlakovic, a Croatian-trained pathologist. In 1996, while she was at the University of Minnesota, she published a study on 6 autopsy specimens from patients with a condition known as hyperplastic polyposis syndrome. Prior to her study in 1996, hyperplastic polyps were considered the only type of serrated lesions, and they were considered to be benign. She noted in her study that 4 out of 6 of these patients had coexisting adenocarcinoma, arising from polyps that were serrated, but that didn't quite look like the normal hyperplastic polyps. Her work really challenged the dogma that all serrated polyps were benign, and she is considered the first documentation of carcinoma-associated serrated polyps. She followed that study up in 2003, in which she and her co-authors reclassified these lesions as sessile serrated adenoma. And this was a call to separate this new class of lesions from hyperplastic polyps based on key distinct histologic features and their malignant potential. Again, she is kind of a leader in the field of colon polyps and challenged the existing dogma that serrated polyps were all hyperplastic and that they were benign. And which brings us to the current conceptual model of colorectal carcinoma. There are actually 2 arms to this pathway, the conventional adenoma pathway and the serrated pathway. The conventional adenoma pathway is thought to develop along that typical adenoma to carcinoma sequence, a slow accumulation of mutations. The serrated pathway has multiple different types of lesions, and unlike conventional adenomas, not all serrated lesions have malignant potential. Studies estimate that the serrated neoplasia pathway contributes to the development of 15 to 30% of all colorectal cancers. So why should you care about this? Well, maybe you're a gastroenterologist and one of the coolest people in the hospital, and you just have a real burning desire to learn more about colon polyps. Or maybe there are people in the audience who are primary care physicians and you need help sorting through this complex mess of risk factors, nomenclature, and recommendations in order to counsel your patients. Or let's be honest, maybe you just turned 50 or 45 now and just had your first colonoscopy in which a serrated lesion was removed, and you want to learn more about what it means for your own health and your children's health. So what are sessile serrated lesions? The name sessile comes from a descriptor of its morphology. Here's a picture of some morphologic specimens, and you can see here that sessile lives somewhere in between pedunculated and flat. They're little dome-shaped and slightly elevated. This is an image from a colonoscopy, which shows the typical appearance of one of these lesions. The word serrated comes from its histologic features, which include asymmetric dilatation, horizontal or lateral growth of the crypt, and deep serrations deep into the crypt. The results in a specimen that looks kind of sawtooth or like a serrated knife. You can assume that some of this is challenging to do because it depends on each crypt being a little bit different. If there are a few number of crypts that are distorted, or if the changes are really subtle, it can be really tough for pathologists to identify which lesions are sessile serrated lesions. And there's a lot of literature showing how there's high interpathologist variation between calling these lesions serrated. Lastly is the word lesion, and it's pretty complicated, and I'll touch on it a little bit. Things changed significantly in 2019. So the WHO publishes a blue book for pathologists titled the WHO Classification of Tumors of the Digestive System. They publish a new edition of this work about every 10 years. And in 2019, the most recent edition was published, which was the 5th edition. One of the key changes was an update in the nomenclature. Before 2019, these lesions were called sessile serrated adenomas by some and sessile serrated polyps by others. Those who used adenoma preferred the term because it kind of displays the malignant potential of these lesions, while others preferred the more neutral term polyp. Finally, in the most recent 2019 classification, they actually settled on the term lesion, which they thought would be an accurate and unifying term. While this seems pretty trivial, it's really important to get terminology correct so you can build homogeneous cohorts for future studies. I think what this just shows is that we're really struggling to kind of put our finger on exactly what these lesions are, and that all of this is new and evolving. The other big change was a change to the histologic criteria. Kind of talked about how it was difficult for pathologists to diagnose or to classify these serrated lesions, and they actually reduced the histologic criteria to include a single unequivocal distorted crypt, known as the one crypt rule. This made it a little bit easier for pathologists to diagnose stuff and actually increase the sensitivity of diagnosis of these lesions. This chart's really awesome, and I think it highlights why the changing histologic criteria is so important. So what we see in this graph, the red circle are actually hyperplastic polyps, and the blue portion of this is the number of the hyperplastic polyps that were reclassified as serrated lesions with each iteration of the WHO. So that you can see with each new edition of the WHO, we're changing more and more of these serrated polyps to sessile. We're changing more of these hyperplastic polyps to sessile serrated lesions. Generally speaking, there are 3 accepted types of polyps in the serrated class. The first I'll mention here are the hyperplastic polyps. These are the most common types of serrated lesions. They're benign. They're small, usually smaller than 5 millimeters. They're flat or sessile in morphology and reside primarily in the distal colon. The next class of lesions are the sessile serrated lesions. This will really be the predominant focus of my talk, and a lot of the work is done to try and differentiate these lesions from hyperplastic polyps. Unlike hyperplastic polyps, these lesions have malignant potential. They're usually a little bit larger than the hyperplastic polyps. They're 5 to 7 millimeters. They're flat and sessile in morphology and reside predominantly in the proximal colon, meaning past the splenic flexure and the transverse, descending, or cecum. Traditional serrated adenomas are the rarest type of these lesions. They're usually much larger than the sessile serrated lesions. They're more polypoid or pedunculated, and they exist most often distally. So now that we know more about these lesions, what are the prevalence of these? What are the risk factors for developing them? What are these molecular features? And what is the risk of progression to cancer? Well, unfortunately, the prevalence is really difficult to determine due to the difficulty in detection of these by endoscopists. I'll spend a considerable amount of time discussing endoscopic detection of these lesions, but suffice to say it's very challenging. Prevalence estimates from epidemiologic studies are limited by this variable detection rate, that high interpathologist variability, and the changing nomenclature. So how can we get an idea of what the estimated prevalence is? Well, as we'll talk about later, challenges of endoscopists in detecting these can be overcome by procedure volume and experience. So you can assume that centers that have high volume and high experienced endoscopists, their values are probably most closely correlated to the true prevalence. With that said, the estimated prevalence is about 13 to 20% in average risk patients undergoing colonoscopy. So what are the risk factors for the development of SSLs? Well, white race is a consistent risk factor in the US and European studies, whereas Black, Asian, and American Indian Alaska Native populations have a lower prevalence of these lesions. In a large US study with data from 1.6 million colonoscopies, white men and women had a 2 to 3-fold increased risk of SSLs compared to Black or Asian individuals. Other risk factors include a family history of colorectal carcinoma or a personal history of premalignant serrated lesions. Interestingly, age and sex are not strong risk factors, and that's pretty much in direct contrast to the risk factors for tubular adenoma, which increase with age and male sex. A pooled analysis from the Nurses' Health Study and Health Professionals Follow-Up Study reported that users of tobacco had about a 2.5 to 3-fold increased risk of SSLs. There's also some literature to suggest that alcohol is modestly associated with an increased risk of SSLs with an odds ratio of 1.1 to 1.8 compared with non-drinkers. And lastly, there's some conflicting data, but presumably there's about a weak association between BMI and SSLs. Okay, now I'll attempt to distill down the molecular pathways to carcinogenesis. This is super complicated, and I will only focus on some portions of this schema. And I do want to say that this is an incomplete picture of the whole story. Again, I want you to think back to those two branches of the pathway. You have the conventional pathway and the serrated pathway. It's believed that mutations in this APC gene, the Adenoma-Deiss polyposis coli gene, is the first pathogenic mutation for the conventional tubular adenoma pathway. Whereas for the serrated pathway, the first step is mutations in the BRAF oncogene. What I really want to discuss right now and focus on for a couple minutes is this microsatellite instability pathway, or the MSI pathway. If you think back to medical school and first aid for step 1, you probably remember microsatellite instability in the context of these things, the Lynch syndrome tumors. But I want to point out to you that it also arises from the serrated pathway. The key oncogenic step after BRAF mutation is the epigenetic methylation of MLH1. MLH1 is one of the DNA mismatch repair genes. Once that's methylated, and specifically when it's methylated at these islands called GPC islands, it turns off this DNA mismatch repair gene. This phenotype is known as CIMP, C-I-M-P, which stands for the GPC island methylator phenotype. These microsatellite instability high, CIMP high lesions don't have functional DNA mismatch repair proteins, and these lesions progress really rapidly from normal colon to carcinoma. Again, each tumor is highly variable, and there are a lot of different genetic factors at play. There's a lot of overlap, but I do want you to remember this MSI high, CIMP high pathway via the serrated pathway, BRAF, MLH1, CIMP high. These are very high risk to progress to cancer. So what is the risk of cancer with an SSL? Many patients will have some serrated class lesion resected at colonoscopy, and most of the time, those are going to be the benign, the really diminutive, the distal hyperplastic polyps that have no malignant potential. However, 13 to 20% of patients will have SSLs. Not all SSLs have MLH1 hypermethylation and microsatellite instability. However, those that do have that phenotype progress very rapidly to cancer. Not every polyp gets genetic testing, but regardless, numerous epidemiologic studies have shown that these patients with SSLs have an increased risk for cancer. And when we talk about the risk of cancer, we can break this down into three different types. Synchronous, meaning they find an SSL on colonoscopy. What is their risk of having a concurrent cancer or advanced adenoma on that colonoscopy? The risk of metachronous or future cancer, and then interval colon cancers or colon cancers between a negative colonoscopy and their next screening test. So we'll talk a little bit about synchronous tumors. So in a large study from UCSF with over 4,000 patients, Lee et al. Found that the presence of large serrated lesions was a strong predictor of advanced colorectal neoplasia with an odds ratio of 3.24. In another large VA study, patients with proximal serrated lesions were twice as likely to have advanced adenoma with an odds ratio of 1.9. In that same study, patients with large serrated lesions were over 3 times as likely to have concurrent advanced adenoma. Again, the risk factors seem to be large and proximal for synchronous advanced adenomas. What about future cancer? I think this is a very important question in terms of like building guidelines and screening intervals. There's ample data to suggest that there is an increased risk of metachronous cancers with SSLs. Erickson et al. In a very large Danish study found that the risk of metachronous advanced neoplasia, even in those low-risk serrated lesions, is comparable to that of high-risk conventional tubular adenomas. This is important. A lot of the literature talks about tubular adenomas, and if they are advanced, you should get colonoscopies more frequently. What this study shows is that even the low-risk serrated lesions have risks that are comparable to high-risk tubular adenomas. This was part of a growing amount of literature that were calling for changes to the current surveillance recommendations. Another study estimated that the risk of metachronous colorectal cancers in patients with serrated lesions may be as high as 12.5%, and that the median interval of about 8.3 years between detection of one of these lesions and diagnosis of colorectal cancer. Lastly, I want to talk about interval colorectal cancers. So again, colorectal cancers that are identified in the surveillance period after a complete colonoscopy are termed interval cancers. These are cancers that either weren't detected on that first colonoscopy or developed so rapidly between the time of that negative colonoscopy and before the next one. Interval cancers are usually caused by precursor lesions that rapidly progress, evade detection, and foil attempts at resection. Not all interval cancers are of serrated origin, but a lot of people in the literature believe that they are. So why is this? Well, many of these interval colorectal cancers are SIMP high, MSI high. They're proximal and related to incomplete resection. We've already talked about some of the genetic features of the serrated lesion, specifically that SIMP high, MSI high genotype. In the next portion of the talk, I'll talk about how challenging these lesions are to detect in the proximal colon. And another challenge of these lesions, which is a little bit out of the scope of this talk, but a great GI talk, is how it's challenging to resect these from the colon. Taken together, it's felt that the serrated lesions contribute to the failure of colonoscopy to prevent proximal and interval colorectal cancers. So to summarize, the serrated pathway accounts for about 15 to 30% of all sporadic colorectal cancers, and the risk of cancer arising from serrated lesion increases from distal to proximal, from small to large, from benign hyperplastic polyps to the more advanced serrated lesions like the SSLs, the SSL with dysplasia, and traditional serrated adenomas. So let's go back to this evil Spock metaphor. Now, I hope you can appreciate some portions of this, that serrated lesions have multiple aliases, meaning that they have inconsistent nomenclature. They're very difficult for witnesses to detect, which are the pathologists, and they can be very impulsive, meaning they can progress rapidly along this microsatellite instability. Okay, let's shift a little bit to talk about endoscopic detection of serrated lesions. So disclaimer, I have never done a colonoscopy or endoscopy before. I have practiced on this rubber box in medical school, but I don't think it really translates to the real thing. Thanks to Dr. Grimes and the GI department, hopefully I will be doing a lot of these in the next 3 years, and I'm really excited to get started in July. All right, the purpose of this slide is just to show you how subtle these lesions are. Without these yellow arrow signs, the classic radiology arrow sign, it may be tough to differentiate these lesions from the surrounding mucosa. A lot of work is being done in the literature to try and identify key characteristics of these lesions to help gastroenterologists when they're doing colonoscopies to help identify and remove these. So what are those characteristics? The first defining characteristic is related to size and location. So like we talked about, most or about 75 to 90% exist proximally. They're a little bit larger than their hyperplastic relatives. They're about 5 to 7 millimeters. Next is their morphology. Generally, they're described as slightly elevated. And here are some pictures that can show that. Again, these are either sessile in morphology or frankly flat. The other thing they describe is this cloud-like surface appearance. So the lesion on the left is a serrated lesion. You can see that it's kind of lumpy, bumpy, and does look like a cloud. The lesion on the right is an adenoma, and you can see more of this smooth surface appearance. Then in terms of color, they describe indistinct borders and pale colors. The lesion on the left is a serrated lesion. You can see how tough this is to differentiate due to its indistinct borders and pale color. You can tell that this might be difficult to detect, but also hard to completely resect if you don't know where this lesion ends. The lesion on the right, again, is an adenoma and is really just here to show you how sharp these borders are and how different it is from the serrated lesions. Next, I want to talk about the mucus cap. So luckily, one hallmark is this adherent mucus cap. In a 2011 GIE study, they found that approximately 2/3 of serrated lesions are covered by this yellow-brown mucus cap. Subsequent papers have tried to use that mucus cap plus other endoscopic characteristics to create predictive scoring systems for serrated lesions. Since this cap kind of helps outline these lesions, it's leveraged as basically a visual cue. Because it's so important, endoscopists have to be careful not to wash this mucus cap off, because if they do, then it can be very challenging to find these. The better the colon prep, the less washing needs to be done, the more these mucus caps can be identified. We're going to come back to these mucus caps, but suffice to say they are very important for identification. Another differentiating feature of serrated lesions is the lack of superficial vessels or the presence of few or isolated lacy vessels. This might be really hard to appreciate endoscopically, but it does have very significant implications. Because these lesions have fewer surface vessels, they're less likely to bleed and shed hemoglobin or other DNA material into the bowel lumen. Again, more on this to come later. On the lesion on the right, we see a serrated lesion, which kind of looks more pale, where on the right, we see an adenoma, and you can see that the surface vasculature is different between the two. Lastly, and least apparent, is something called the pit pattern. And recently, the type 2O pit pattern has been shown to be a hallmark of these lesions. Studies have estimated a sensitivity of 66% and a specificity of 97% of SSLs with the type 2O pit pattern. Again, the characteristics are location, size, this kind of confusing morphology, although sometimes they have a cloud-like appearance. They have indistinct borders and that pale color. They have this mucus cap, few or isolated lacy vessels, and this type 2O pit pattern. So accurate detection of these lesions depends on two things: technology and knowledge. Technology can be leveraged with things like high-def colonoscopes that can really magnify these images and produce sharp resolution for fine detail discrimination. I didn't have a chance to talk about some of the other technologic tricks, but there's stuff like narrowband imaging, and chromoendoscopy that can help contrast these lesions from the surrounding mucosa. Those tools aren't available everywhere, but they are used at the UW and the DHC. The last is about knowledge and pattern recognition. Looking for these clues such as the mucus cap and the pip pattern could be extremely helpful in identifying these. So what can be done to improve detection of these super subtle lesions? Well, one is to lengthen withdrawal time. Inspection of the colon for polyps and cancer mainly takes place during the withdrawal phase of colonoscopies. The mean withdrawal time is defined as the time between cecal intubation and procedure completion. A threshold of 6 minutes has been linked to lower post-colonoscopy cancer, and practice guidelines recommend a minimum of 6 minutes for withdrawal time. In this study from Clinical Gastroenterology and Hepatology in 2022, they randomized patients to a 6-minute withdrawal time versus 9-minute withdrawal time. And they found that prolonging the withdrawal time to 9 minutes significantly improved adenoma detection rate and also resulted in a modest increase in serrated lesion detection rate. Another intervention associated with an increased serrated lesion detection rate is the use of split-dose bowel prep. Split-dose bowel prep involves dividing the volume of bowel prep into 2 doses, one the night before the procedure and the other about 4 to 5 hours on the morning of the procedure. The figure on the left shows that split-dose bowel prep, or SDP, resulted in higher rates of good or excellent bowel prep. And on the right, you can see that this resulted in nearly a doubling in the sessile serrated polyp detection rate with a p-value of 0.53. The increase in SSL detection is likely due to improved cleansing of that proximal colon. Lastly is procedure volume. The graph on the left is taken from a large multi-centered cross-sectional study from 2018 that showed that with increased procedure volume, the odds ratio of detecting a serrated polyp increases, and that's likely due to pattern recognition. You can then kind of deduce that if it's related to pattern recognition, that teaching interventions on pattern recognition could probably help increase detection rate. And that's what was exactly done here in a 2020 study that showed that after 2 separate training sessions, 3 years apart, the rate of detection of sessile serrated lesions increased significantly. The take-home point here is that to ensure adequate detection of these lesions, endoscopic quality needs to be maintained. Things like high-definition colonoscopes should be used. An aspirational goal of 9 minutes should be targeted for withdrawal time, and the use of split-dose bowel prep should be utilized. Another key marker of endoscopic quality is the adenoma detection rate, or ADR. Multiple studies have shown an inverse correlation between ADR and the risk of colorectal cancer. The higher the ADR, the lower the risk of colorectal cancer. According to endoscopic screening guidelines, the ADR is set at 25% nationwide. There's some literature to suggest that detection of serrated class lesions may mirror adenoma detection rate, meaning that serrated detection rate and adenoma detection rate may be correlative. However, there's no specific target for sessile serrated lesion detection rate in the guidelines. There's been a growing focus on serrated lesion detection rate as an additional marker of endoscopic quality. This is data that was provided to me by Dr. Mark Benson in the Division of Gastroenterology. He does QI work in addition to other research studies on adenoma detection rate within the group at UW as a means of ensuring endoscopic quality. Each bar here represents an individual endoscopist, and the N is the number of endoscopies performed. This is a massive undertaking to do every year, and you can see that some providers have done hundreds of screening colonoscopies. The important part here is to show again that the national benchmark is 25% for adenoma detection rate, and that the group's detection rate is 37%, well above that set cutoff. This is data from the same year, 2020, looking at serrated polyp detection rate. What you can see here is that there's a way larger variation between providers in terms of the serrated lesion detection rate. And you can also see that there are some providers that are clearly excelling in detecting these. So what makes them so good? Should we be studying their technique? And what else we see from this graph is that the mean is about 11%. This is higher than the generally accepted sessile serrated lesion detection rate of 7%. Dr. Benson's doing ongoing work on trying to identify what can be done to improve this rate. So hat tips to Dr. Benson for sharing his work. Okay, back to our metaphor. So now I hope that we can piece on some more layers to this, that these lesions hang out in the bad neighborhood of the proximal colon. They hide behind this mask of mucin, and they're difficult for the endoscopist or the police to find. They're really tough to remove from society, which is related to their high incomplete resection rate. For the last introductory portion of this talk, I'll be talking about screening for serrated lesions. So lots of randomized control trials have proven that screening average risk individuals helps reduce the incidence and mortality from colorectal cancer. One subtle point is that other screening programs like lung, prostate, and breast really look for detection of early stage cancer. In contrast, colorectal cancer screening focuses on detection of early stage cancer, but also the detection of these precancerous polyps, which can be removed and prevent cancer. So what are the options available for colorectal cancer screening? There are the invasive and the direct visualization of the mucosa with colonoscopy and sigmoidoscopy. There are also the stool-based tests, the fecal immunohistochemical test, commonly known as FIT, and the multi-target stool DNA test, commonly known as Cologuard. Then there's one last direct visualization test that doesn't really fit nicely with the others, and that's the CT colonography, also known as virtual colonoscopy. Despite the proven benefits of colorectal cancer screening and the general consensus recommendations by most professional societies, an estimated 31.2% of eligible adults in the US have never been screened for colon cancer. So how do we close that gap? How do we get everyone screened? Maybe it's these non-endoscopic methods that are an attractive alternative to patients who maybe don't want to go through a full bowel prep. They can't risk missing 2 days of work. They don't want a full bowel prep, or they don't have chaperones for their procedures. So each of these tests have different test characteristics, sensitivities, and accuracy. Which of these tests is best? Well, it's certainly a complex and involved discussion, but it has to weigh factors such as patient preference, family history, access, and test characteristics. Like we talked about before, it's really important for these tests to detect early cancer as well as precancerous lesions from both arms of the carcinoma pathway, the advanced adenoma arm and the sessile serrated lesions. Unfortunately, none of these tests are perfectly suited for detection of sessile serrated lesions, and each have their own limitations. So while colonoscopy is the criterion standard for detection of all precancerous lesions, we just spent a lot of time discussing how difficult it is for them to detect these subtle lesions. Sigmoidoscopy is even more limited in that it fails to reach the proximal colon where a lot of these lesions are found. We also talked about how these lesions have few superficial vessels. This makes the sensitivity of the stool-based tests like FIT and multi-target stool DNA very limited because they are dependent on shedding of that material into the bowel lumen and the stool. Lastly is the CT colonography, and that's also hampered by morphology. I'll spend some time now focusing on multi-target stool DNA and CT colonography. The multi-target stool DNA test is an exact sciences test produced out of Madison. It received FDA approval in 2014, and since then, over 1 million of these tests have been ordered. The test is considered to be a third-generation stool-based test. The first generation were those guaiac-based fecal occult blood tests, including the high-sensitivity FOBT. The second gen were the fecal immunohistochemical tests, which utilizes an ELISA assay and antibodies to detect hemoglobin rather than that cumbersome guaiac-dependent reaction. These multi-target stool DNA tests are the third generation because they include the immunohistochemical portion of the FIT test with an additional molecular assay for aberrantly methylated BMP3, NDRG4, mutant KRAS, and beta-actin. I want to dive a bit into the landmark study in 2014 by Imperiale et al., which helped validate that multi-target stool DNA test as a screening modality. In this test, nearly 10,000 patients underwent FIT, multi-target stool DNA, and colonoscopy testing. The primary outcomes were detection of colorectal carcinoma, and the secondary outcome was detection of advanced adenoma and sessile serrated polyps. This figure shows that multi-target stool DNA outperformed FIT in sensitivity for all colorectal cancers by all locations. I do want to highlight this figure on the bottom left here. The results show that multi-target stool DNA test outperformed FIT for the detection of high-grade dysplasia, and more impressively, look at this graph for the sessile serrated polyp detection. The sensitivity of multi-target stool DNA test for large serrated polyps was near 42%, while FIT was only 5.1% sensitive. This study showed that the multi-target stool DNA test outperformed FIT for detection of colorectal cancer, advanced precancerous lesions, and that actually the multi-target stool DNA test achieved its greatest relative performance in relation to FIT, specifically in the detection of those large serrated lesions. The authors attribute this to the DNA panel, which is in the multi-target stool DNA test. So now that we know about the stool-based test, let's talk about the last direct visualization test, CT colonography. This is a picture of the UW Health's virtual colonoscopy team. Big shout out to Dr. Pickard here, who is circled in the middle. He's one of my mentors and really a prolific researcher. He and this group have published extensively on CT colonography, including New England Journal of Medicine articles, as well as other numerous high impact publications. They've performed over 10,000 CT colonography cases and are leaders in the field. So you may be wondering what goes on in a CT colonography case and how to counsel your patients on what to expect. Similar to other direct visualization techniques, the bowel needs to be prepped for adequate visualization. Importantly, the prep is different than a typical colonoscopy in prep. It includes bisacodyl tablets, some mag citrate, barium sulfate, as well as iohexol contrast. The colon is then insufflated and a CT scan is performed, after which 2D and 3D renderings of the colon and rectum are created. Patients are found to have large polyps. A same-day colonoscopy is tried to arrange for, so patients don't have to prep twice. CTC, or the CT colonography, has been studied and used since like the early 2000s. Its performance in detection of high-risk adenomas and colorectal cancer is well known, including a very high impact publication in the New England Journal of Medicine from UW, from the Division of Radiology and the Department of Gastroenterology. However, with a growing recognition of the SSLs, there has been a lack of studies investigating CT colonography for detection of these lesions. So this is exactly what the aim of this published study by I.J. Speert et al. This was a post hoc analysis of the Cuckoos trial, which was done from 2009 to 2010 in the Netherlands, in which patients were randomized 2-to-1 to colonoscopy or CT colonography. Importantly, this group defined high-risk SSLs as large, greater than 10 millimeters, or dysplastic lesions. Here are a few results from the study. I'll focus your attention on table 1, which shows that colonoscopy detected high-risk SSP and large SSPs and SSPs with dysplasia at a higher frequency than CT colonography, and all of these values were significant. Moreover, in table 3, we see that CT colonography failed to identify proximal high-risk SSPs in this cohort. In summary, this study showed that the detection of high-risk SSLs was higher with colonoscopy compared to CTC, and that flat SSLs in the proximal colon were often not detected with CTC. However, the bowel prep used in this study only had one iodinated agent, and it's a significantly different prep than the one used in the US and at UW. They may seem trivial, but it's an important point. This was a study published by Dr. David King and Dr. Perry Pickard, in which they studied almost 10,000 CTC exams and studied the prevalence and characteristics of serrated polyps. They found that actually the tagging contrast agents which were used in the bowel prep can actually help in serrated polyp detection. Notably, the barium and the contrast agent actually admixes with that mucin cap on serrated lesions and helps highlight these lesions on CT scans. This was further validated by the fact that half of occult serrated lesions in this series were able to be identified in retrospect. This is really important because it shows that there's a utility in CTC in detection of these lesions beyond just morphology. This mucin cap can really be leveraged in optical diagnosis and in CT studies. And here's an image of what I'm talking about. You can see that this is a serrated lesion in the proximal colon, and you can see how flat it is. However, the admixing of the barium and the mucin cap kind of highlights this lesion and helps kind of lift it off of the mucosa in terms of a visual cue. And that brings me to my research project. So in general, there's pretty sparse literature comparing screening modalities to each other. And we're really lucky to be at an institution with such a strong CTC group here at UW. And it's a unique opportunity to study this screening modality thanks to these large cohorts in the radiology department. I was interested in comparing the key performance indicators of the multi-target stool DNA compared to CTC. Multi-target stool DNA test was only recently added to the screening guidelines and hasn't been compared to non-stool-based tests such as CTC. And specifically, I was interested in high-risk SSL. Similarly to IJ Speert, we defined high-risk sessile serrated lesions as large and/or dysplastic. While a lot of this is evolving, we're still really kind of struggling to identify which serrated lesions are at highest risk of progression to carcinoma. There are some widely accepted risk factors, including location, size, and dysplasia, but attempting to put a name on this and defining them as high-risk serrated lesions is important for studying this group and really identifying the risk factors for progression from high risk to cancer. And this is important for identifying surveillance frequencies. Again, the novelty of this study was that we were trying to study high-risk SSLs, and we created this term, high-risk sessile serrated lesion. Our PICO question was as follows. The population were asymptomatic patients undergoing colorectal cancer screening, and we created two matched cohorts of about 4,000 patients in each arm. The intervention was colorectal cancer screening, and we compared CT colonography to multi-target stool DNA. The outcomes of interest were the test characteristics of the screening modalities. Specifically, we were looking at diagnostic yield, which is the histologically proven detection rate, and positive predictive value for advanced neoplasia and high-risk SSL. One key feature of CT colonography is that polyps are assigned a CRAD score, similar to the BI-RAD score for breast cancer. With this, we could set different thresholds for positivity, which correlates to polyps at different sizes, like 6 millimeters, 10 millimeters, and 3 centimeters. This slide shows my main data. For multi-target stool DNA tests, the test positivity rate was 15.2%, and 13.1% of all patients were then referred to colonoscopy for follow-up. The positive predictive value for advanced neoplasia was 22.7% for advanced neoplasia and 5.5% for high-risk SSL. The overall yield for advanced neoplasia was 2.7% versus 0.7% for high-risk SSLs. Conversely, at the CTC level, we could analyze this at two different thresholds, the 6 millimeter threshold and the 10 millimeter threshold. As you would expect, the test positivity rate at 6 millimeter threshold was much higher than at 10 millimeters, and similarly for colonoscopy referral rate. The positive predictive value for high-risk SSL was 14.4% at the 6 millimeter threshold and 25% at the 10 millimeter threshold, while the overall yield was 1.7 at 6 millimeters and 1.6 at 10 centimeters. Taken together, there is a much higher overall yield and positive predictive value with CTC at both thresholds compared to multi-target stool DNA. So in conclusion, in two equally sized cohorts at the same institution, CTC had higher diagnostic yield and positive predictive value for high-risk SSLs than multi-target stool DNA. The yield of 1.7% was much higher than 0.7% in multi-target stool. And this 1.7% is close to the numbers cited in the literature, but much higher than that number published by IJ Speert et al. This data is really important and should be used in these complex discussions regarding screening for precancerous polyps. However, Further information needs to be done and further studies need to be completed to actually get sensitivity and specificity. Those studies would require all patients to undergo colonoscopy, even those with negative screening exams. This may be costly and time consuming, but very important in terms of understanding full test characteristics of these screening modalities. All right, let's jump back to the case briefly. So this 50-year-old who underwent screening with a multi-target stool DNA, followed by colonoscopy, identified a 13-millimeter sessile serrated lesion in the transverse colon. What does it mean? Are these different than normal colon polyps? Are these rare? And what's my risk of developing cancer? Well, serrated lesions are a different class of polyp. The type that she had is precancerous, and if left in place, could develop into cancer. Are these things rare? Well, we talked about how the prevalence is somewhat unclear, but approximately 13 to 20% of patients will have an SSL detected on colonoscopy. These lesions are responsible for up to a third of sporadically occurring cancers. What's my risk of developing cancer? Well, having a large serrated lesion on the right side of your colon is associated with an increased risk of colon cancer in the future, and you should get screened again in 3 years. What about future directions? Well, like I talked about, more research is needed to fully describe the natural history of these lesions. We need to further define what high-risk SSLs are and try to approximate the risk of cancer. Based on this risk, the GI community needs to continually review and reassess appropriate screening intervals for patients with high-risk lesions. Recent guidelines for surveillance have now included weak recommendations with very low quality evidence for patients with multiple dysplastic and large SSLs. Time will tell if these new intervals will result in changes in sessile serrated lesion detection rate and reduced rates of interval colon cancers. We also need to continue to work on improving detection of these lesions by screening tests and colonoscopy. Full performance of screening tests should be assessed for SSLs, so sensitivity and specificities can be calculated. And I think there's a wonderful opportunity for educational initiatives within trainees and clinicians to help improve this on endoscopy. I'll leave you with this photo one last time to remind you of this evil twin metaphor. And then I want to give a couple special thanks. Thank you to my Grand Rounds team, specifically Dr. Weiss. She was such a huge help with this project from the beginning of the idea all the way to the data processing to the publishing. I really appreciate her time, her wisdom, and her knowledge. And thank you so much for being with me along this way. I also want to give a shout out to Jamie Lamantia, who is a research specialist and works with Dr. Weiss, who is super helpful in terms of the submission process. Thank you, Jamie. Big shout out to Dr. Pickard in the radiology department for teaching me all kinds of skills and how to write efficiently. Thank you, Dr. Benson, for your data and help formalizing my thoughts. Dr. Jeremy Smith for helping me kind of improve this presentation. Thanks to the Department of Medicine team, Andy Coyle, for introducing me and guiding me throughout this year. He's only been here since September, but I really feel like he and I have a great relationship, and I really appreciate all your mentorship. Dr. Sean O'Neill's my chief mentor, Dr. Zakowski and Dr. Schnapp for your mentorship and encouragement. My life supporter, Dr. Jenny Toomba, hope she's still on the call. She is clearly my better half. My co-chief resident team, Dr. Scott Lorenzo, Lindsay Matthews, and Emily Owen. I really couldn't have gotten through this year without these three. They were excellent compadres. They were great co-workers, and I really enjoyed all our dinners, laughs, and memories together. Thanks for helping me get through this year. And then the rest of the GI department, thanks Dr. Grimes, Dr. Lucy, and Arnold Wald for accepting me into the program. I'm really excited to get started July 1st. Thanks, everyone.
Great. Thank you so much, Nimrod, for a wonderful discussion and overview of sessile serrated lesions. Perhaps you can stop sharing for a second.
Yes.
While you're doing that, there's a question from Noelle Acante, more about the 30% plus patients or people who never get screened. Access as well as insurance coverage may play a role. What do you think the different screening methods can add to that, or other opportunities to improve access to all of our patients?
Yeah, it's a really interesting question, and I think it's a really important question to be asking. I know there's some interesting stuff done at the VA with Dr. Ryan Smith and Dr. Hannah Bell and a couple of the other residents in terms of trying to coordinate colonoscopies for homeless veterans in terms of getting them a place to stay overnight and also coordinating rides. It's really tough, and I think that the more screening modalities that are out there, the more opportunity it is to kind of catch more patients. If, with these two-step tests, you have a positive test, that's at least their first step in the door before they can get to full colonoscopy. I think some of the recommendations will say that any screening test is better than no screening test. So I think that there's like a lot of opportunity to catch more patients than we do currently.
And also there have been changes in insurance coverage recently, right, that allow that insurance companies will now pay for a colonoscopy following the a positive screening test by colonoscopy.
Yeah, which should definitely help increase our kind of detection rates. And again, trying to close that screening gap.
Yeah. So I have a question. You talked about obviously the role of volume in detection rates, et cetera. So as a consumer, I need my screening colonoscopy. How do I get access to information about the volumes of different providers and their detection rates?
That's a great question that I don't have the answer to. I think a lot of that data tries to hammer home the point that not all people who do colonoscopies are gastroenterologists. So there are some colorectal surgeons, general surgeons, or family practitioners that may be doing these procedures. Whether they're doing those procedures because access is limited in certain areas is another discussion. But they try and hammer home the point that gastroenterologists who are kind of keen at pattern recognition are better at identifying these serrated lesions in particular. And so presumably going to a center that's high volume, that has a lot, like a tertiary referral center, will increase the likelihood of somebody having a high volume practice.
Yeah, although the data you showed from our practice, that even within a tertiary care center, there's high variability.
There sure is.
Yeah, and there's a comment from Jen. Which ended. Sorry, Jen. I think it got cut off. 880 as well as our 8. So Jen is saying, I think what Jen is saying is that the information about volume and detection rates are not available publicly.
And Dr. Benson's doing a lot of work on like the QI side of things, and that's kind of internal quality control to make sure that we're providing high quality endoscopies for our patients.
And then there's another comment from Noelle. Sounds like you need to contact Noelle because she's doing an environmental scan of colonoscopy access in Wisconsin. So it sounds like a potential additional research project there.
And shout out to Dr. Weiss. She does, as my mentor, she was super helpful in the understanding colorectal cancer, but also screening. And so she's doing work too, looking at rural urban disparities with Gabby Waklavic in terms of kind of identifying what those risk factors are and how we can kind of overcome some of those barriers to screening within our state.
Great. Well, again, a wonderful talk. And I also want to really highlight it and applaud you for the research project that you were able to accomplish. I think you started as a resident in that project, if I'm correct,
Yep.
Which is not an easy thing to do, and to take it from inception to getting a first author publication is really an amazing accomplishment that you should be quite proud of. Also says a lot for your mentorship. So great work, Jen, and the entire team. Really impressive talk. And thank you, Jeremy, also for all of the work that you've done with not just Nimrod, but all of the our speakers.
Thanks, Dr. Schnapp. That was extremely kind. Thanks again to everyone who helped me along the way. And I hope you guys enjoy this rainy Friday.
Great. And now you can relax. Yes. Thank you, everyone. Take care. Bye-bye.
Bye, guys.